Okay, let's talk about this really cool case of a lateral ankle sprain. This was a 35-year-old male amateur tennis player who presented with right ankle pain. He basically says he stepped on a tennis ball on the court, accidentally, of course, and felt immediate onset of pain in his ankle. He fell to the ground. He thinks he had an inversion mechanism. He was unable to get up and walk after and needed help off the court. Didn't continue playing. Basically, pain and swelling, no numbness, tingling, and no history of ankle sprains that he can remember. And this is a healthy 35-year-old male, no medical or surgical history. On exam, you see some obvious swelling and bruising of the lateral ankle. There's no frank deformities. The skin is intact. He is tender along the anterior talofibular ligament and the calcaneofibular ligament with no bony tenderness. Range of motion is deferred. His plantar and dorsiflexion are intact. He did not tolerate a jaw test very well. His inversion test was painful, but no obvious laxity, and a negative squeeze test. He was neurovascularly intact, and his gait was antalgic. He really didn't walk very well. We did obtain some x-rays, which can be seen here. From left to right, you have the PA view, the lateral, and the oblique or mortise view, which is the most useful. So the mortise view gives you a great view of the talus here, the tibiotalar joint, and the fibulotalar joint as well. So the whole articulation in the ankle proper, and that space is maintained, which is what you really want to see, probably the most important thing. There's no cortical irregularities of the distal fibula or medial malleolus here. There may be a little bit of subtle soft tissue swelling here, but no obvious bony lesions, right? Although this is not a dedicated foot film, the fifth metatarsal looks okay, the navicular looks okay. You don't see any avulsion injuries. Maybe there's a little bit of posterior calcification here, but that could just be the angle of the beam. And then again, the true AP view looks good as well. So nothing on the x-ray really. We did ultrasound him. He had a very heterogeneous anterior talofibular ligament, was hypoechoic, and he had pain with sonopalpation. We diagnosed him with a lateral ankle sprain. We took him out of tennis, put him in a walking boot, a tall walking boot, NSAIDs ice, started a basic home exercise program. He didn't want any crutches, and we were going to see him back in a week. So let's talk about lateral ankle sprains and just review the ligaments and anatomy here real quick. So the lateral ankle ligaments that are most important are the anterior talofibular ligament, the calcaneofibular ligament seen here, and the posterior talofibular ligament. And those are the ones that are most commonly injured with an inversion mechanism or a lateral ankle sprain, and they kind of tear from front to back, right? So the ATFL always tears first. Other bony landmarks that you care about here would be the fifth metatarsal down here on the side of the foot, and really the posterior part of the lateral malleolus too, if you're worried about any bony injuries. And then you can see the tibiofibular ligaments here as well, which are part of the high ankle, so to speak. And then the Achilles tendon is illustrated as well. So lateral ankle sprains are the number one lower extremity injury in all athletes, up to 30% of some sports, with indoor and court sports most commonly cited. And that's because people are jumping on each other's feet or planting their foot and rolling inwards. And we kind of just described the ankle joint. It's a hinged synovial joint. Not pictured as the deltoid ligament on the medial side. This is what an inversion mechanism looks like. And just by the way our bodies are made, the ankle is much more vulnerable on the lateral side here for an inversion injury as opposed to an eversion injury. And so that can happen by stepping on somebody's ankle or planting your foot and rolling inwards. And then again, you see the ligaments tear here. Usually it's the anterior talofibular ligament and then going backwards to the calcaneofibular and less commonly the ETFL. So some flavor of exaggerated inversion, and those ligaments almost always tear. Acutely, you can have high ankle sprains. You can have medial ankle sprain, which is a sort of different lesion, but they can co-occur. And then you can have a fracture, which of course is not really an ankle sprain anymore, but sort of along that continuum of ankle injuries. More chronically, if you have recurrent ankle sprains, you can develop ankle instability and ankle osteoarthritis, especially if you're not treated well or don't do what the doctor recommends. Differential diagnosis is broad for lateral ankle pain. So we're going to have peroneal tendon injuries, sinus tarsi syndrome, ankle impingement, ankle OA, stress fractures, chronic ankle instability, high ankle sprain, osteochondral defects of the talus. Those are fairly common. Ankle fractures, cuboid syndrome, tarsal coalition, peroneal nerve and sural nerve injuries, and then fifth metatarsal fracture. So pretty broad differential, and you can kind of tease out some of these things based on your history and exam. By history, they're usually going to have some type of twisting or rolling injury. They're going to usually be able to describe it. They're not going to be able to continue what they were doing after, whether that's tennis or jogging or any other sport. They often have swelling and bruising. On physical exam, one thing worth remembering is these Ottawa ankle rules, which are illustrated here. And the big thing would be the lateral malleolus on the posterior aspect and the medial malleolus on the posterior aspect. You want to see if there's any bony tenderness there. Then you want to palpate the navicular in the base of the fifth metatarsal, right? Those are the four sort of bony landmarks that are most likely to be fractured. And then you want your patient to be able to take a couple steps, both clinically at the time of injury and when they're evaluated in the emergency department or clinic, wherever they may be. You usually want to palpate along the anterior talofibular ligament as well as the CFL and PTFL. You'll usually see bruising, and then if they will tolerate it, bruising and swelling. And if they'll tolerate it, drawer test, Tyler tilt squeeze. On the first examination in the acute injury phase, they don't always tolerate that. It's mostly a clinical diagnosis. Imaging supports the presumed diagnosis or excludes other things, right? So X-ray often to exclude other pathology, not always necessary, but often obtained. Ultrasound will show ligament disruption, which you can see here. This is a torn anterior talofibular ligament, and you see the fibula and talus are labeled for us, right? So we're in the sort of front part of the ankle joint, and this is the fibula and talus. Then we see the ATFL, very heterogeneous appearing, and then all this hypoechoic stuff under here, this is all blood. So this is what an ankle sprain looks like sonographically. Very common finding. MRI, you definitely do not need MRIs routinely, but they can show things like tendon rupture, osteochondral defect, syndesmotic injuries, etc. if you're worried about some other more significant or surgical pathology. Management is generally non-surgical. In the acute phase, like we're talking about day 1 or 2, obviously coming out of sport, you want to mobilize them, rest. And when I say early mobilization, I just mean like pedal pumps. They're not necessarily doing anything too wild. In the subacute phase, which might be within the first week or two, progressive weight bearing is tolerated, physical therapy and or home exercises. A lot of athletes like other treatments. I'm not going to get into that. And then some sort of structured return to sport. Our athlete did really well. He came in on week 1, still symptomatic. Gait was normal though. He came out of the boot and started doing some formal PT with one of the team athletic trainers. At week 2, we saw him and he was jogging painlessly and had started some sport specific agility drills. By week 4, he was back on the tennis court, basically going 100% without any pain. The 3 key points about lateral ankle sprains. They are the most common injury in sport, typically occurring as a result of some flavor of an inversion injury. The diagnosis is basically clinical. You know what it is before you even touch the patient. X-ray and ultrasound, though, are useful to exclude other pathology if there's any question. And then treatment is non-surgical, involving immobilization, NSAIDs, ice, and physical therapy. And most athletes will return to play within 4 weeks.